welcome you all to the today's webinar on this very particular day. Today is 18th November, the 19th annual World COPD Day. World COPD Day is organized by the Global Initiative for Chronic Obstructive Lung Diseases, that is GOLD, in collaboration with healthcare professionals and COPD patient groups throughout the world. The 2020 theme for World COPD Day is Living Well with COPD, Everybody, Everywhere. Aiming to raise awareness, share knowledge, and discuss ways to reduce the burden of COPD, we select the topic for today's webinar. And the topic is Goal 2020 Update and Importance of Early Diagnosis and Management of COPD during COVID-19. This webinar is organized by Department of Respiratory Medicine, Evercare Hospital, Dhaka, and our scientific partner is Unimed UniHealth Pharmaceutical, brand partner Provare and Dilbro Unicare. And of course, as always, our broadcasting partner is RAS TV. I would like to thank you all for arranging such a time-demanding webinar. I am Dr. Jannatul Naim Rose, Assistant Surgeon, Shohid Tajuddin Ahmed Medical College, Gazipur, conducting this program as a moderator, and of course, I am very much glad and blessed to be here. Now, let's introduce our research persons present here. Today, we are very much blessed to get our respected guest, Dr. S.M. Abdullah Al-Mamun sir, as our speaker. Sir is working as a senior consultant and coordinator of respiratory medicine, Evercare Hospital, Dhaka. Welcome, sir, to our webinar. We also have some other renowned specialists as our panel of experts. We have with us Professor Dr. Roshni Jahan ma'am, Consultant of Respiratory Medicine, Evercare Hospital, Dhaka. Professor Dr. Shahabuddin Talukdar sir, Senior Consultant and Interventional Cardiologist, Evercare Hospital, Dhaka. We also have Brigadier General Mahbub Noor sir, Senior Consultant and Head of Critical Care Medicine, Evercare Hospital, Dhaka. And we also have Dr. Tasbirul Islam, Clinical Associate Professor and Medical Director, Pulmonary and Critical Care Medicine, Indiana University, Arnett Hospital, USA. And last but not the least, Dr. Adnan Yusuf Choudhury sir, Associate Professor and Head of the Department of Respiratory Medicine, Mugda Medical College, Dhaka. I would like to welcome you all to today's webinar. We also have a very special guest with us, Mr. M.M. Iskandar, Director, Unimed and UniHealth Pharmaceuticals Limited. First of all, I would like to request Mr. M.M. Talukdar to deliver his welcoming speech.
Very good evening. Thank you very much, ma'am. And respected panel of experts, legendary respirologist of Bangladesh, at the same time the speaker, legendary speaker, Dr. Abdullah Al-Mamun, and the other associate doctors. It is really great privilege for Unimed UniHealth Pharma to be a scientific partner of this program. Today is the World COPD Day, and the slogan of with this World COPD Day is the living well with COPD, everybody, everywhere. As you know, it is a progressive disease. COPD is a progressive disease, and during COVID-19, those who are COPD patients, they had to suffer a lot because they could not even reach to the doctor, and they are not accustomed with the digital connectivity or communication. And progression was also held, and also the number of deaths also a remarkable number was present. Everybody everybody knows that this due to COPD in America, this is 1 in 4 people used to die. And in Bangladesh, what is the real picture, we don't know, but around 80 lakhs people are suffering from COPD. And major cause of it, cause of what everybody knows it, the smoking. Smoking is the major cause. At the same time, industrial pollution and environmental pollution is a matter. So to organize this type of program, that is this observance of COPD day, is to create awareness among the physician and at the same time among the patient also, and also the common people. As we know, the COPD is a preventable disease. At the same time, it can be also managed if it can be diagnosed earlier. So today's topics is very much relevant. That is early diagnosis and management of COPD during COVID-19. We are really proud to be attached with this program because we have interest not only to go for business, also create awareness so that people can be benefited out of our involvement. For organizing this program, I want to extend my heartiest thanks to Dr. Abdullah Al Mamun for keeping us as a scientific partner, and also all the panel of experts for giving us this opportunity. Experts like Professor Roshni Jahan, Professor Dr. Shahabuddin Talukdar, Senior Consultant of Liver Care Hospital, Brigadier General Mahabub Noor. He is also a Senior Consultant of Critical Care Medicine, and also from USA, Dr. Tasbidul Islam will attend here. I am also very much well accustomed or acquainted with him. And also Dr. Adnan Isuf Chowdhury is also a professor of Mukta General COVID Hospital. Now it is COVID Hospital, initially that was General Hospital. I think UniHealth was with this respiratory area very much. We are very much active, and we had a huge activities in academic, at the same time providing very quality product. We have been doing it, and we have created that much confidence among the physicians, and that is why they used to give treatment and giving relying totally on our products also. That is a great achievement for UniHealth. So through this program, I hope the physician would be benefited a lot and people would be benefited. Ultimately, smoking cessation and smoking prevention, that might be helpful for the patients as well as preventing the new cases. Thank you again for giving this opportunity for us, especially me, and on behalf of my company. I hope everybody will enjoy this discussion and everybody will benefit. Thank you very much.
Thank you so much. Thank you so much, Mr. M.M. Iskander, for being our scientific partner and helping us to create awareness among the people. Dear audience, if you have any relevant question, let us know. What to do for this is to write your name, age, and your question on the comment box during the live is going on. And of course, don't forget to like the official Facebook page of RAS TV and subscribe the RAS TV YouTube channel. And please do share this live in your timeline and your favorite groups also. Dear audience, I ask that you give your full attention to Dr. S.M. Abdullah Al Mamun sir and help me in welcoming him on the screen to share his presentation on today's topic. Dear Dr. S.M. Abdullah Mamun sir, please.
Okay, thank you for inviting me. Assalamu alaikum, my dear colleague and respected panelists and audience. Assalamu alaikum. Very good evening to you all in Dhaka and good morning in USA. We all know that we are now in the eve of the World COPD Day, and it is in the midst of global pandemic, that is the COVID pandemic. Now, so in this year, our presentation and our all the celebration is in the virtual platform. Today, more than in 50 countries and more than 300 organizations are participating in this virtual platform for awareness, making awareness program, and these all are guided and led by the GOLD Global Initiative of Obstructive Lung Disease. And in Bangladesh, various different organizations, Bangladesh Lung Foundation, Bangladesh Asthma Association, other organizations also celebrating this. And with the Evercare Hospital, Respiratory Medicine Department is always with this type of program. And today we are very happy to celebrate this day-long program of World COPD Day. We have already have some few TV talk already have done in this day. And now we're going to our main program, and this is the, I think, the cheerful program, that is the webinar on the COPD, and that is the update of Goal 2020 and importance of early diagnosis and management of COPD. In the first part of my discussion, I like to discuss with the new changes that comes in this year for the global initiative of obstructive lung disease for the management of the COPD. And finally, I will discuss for the early diagnosis and management during the COVID-19. We know that, dear friends, good chronic obstructive pulmonary disease, COPD, is currently the fourth leading cause of death in the world. And but it is projected to be the third leading cause of death by 2020. And this may be due to the mixing of COPD and the COVID-19 pandemic. And COPD represents an important public health challenge in both preventable and treatable. And COPD is the major cause of chronic morbidity and mortality throughout the world. Many people suffer from the disease for years and prematurely from its complication. Globally, the COPD burden is projected to increase coming decades because the continued exposure of to COPD risk factor and aging of the population. Right now, COVID-19 has created a great threat for the COPD population. Among total death is a large number in current COPD patients. Those patients who are suffering from the previous comorbidities and affected by the COVID-19, the death rate is more, but it is more in case of COPD with the rest of other comorbidities like heart disease, diabetes, and others. So it creates an immense importance to all of our physician community to take care of our patient and to early diagnosis and early management and to continue the management treatment to prevent and to save their life. We know the gold. I just like to few words regarding this because if we are, it was not the fair if we don't utter their name, the global obstructive lung disease, and this is the goal global initiative of obstructive lung disease. This is created in the first 1997 in USA with the USA Heart, Lung, and Blood Institute, and with collaboration of the World Health Organization. From then, there every year the steering committee of the Gold sits twice in year to make some update, some research and the observational study update, and give us information for the management and further treatment of the COPD patient. And there are some changes in every year after 1 year research and observational study and works to give the changes. And recently, we have changes, important changes in the definition of COPD. We know that from our beginning of our life, from the Davidson textbook, we know the COPD is a chronic inflammatory disease of the lung, which is usually progressive and due to obstruction of the airway. But after many research, now scientists has end in the point that the disease is no more progressive. If we treat it, diagnosis is early, treat it early, we can hold the progression. So from this year, from the last year, that is 2019, and finally this year, we remove the term usually progressive from its definition. It's very important and gives us and hope for the COPD patient. Now the definition is like that: chronic obstructive pulmonary disease, COPD, is a common, preventable, and treatable disease that is characterized by persistent respiratory symptoms and airflow limitation that is due to airway and partially alveolar abnormalities, usually caused by the significant exposure to noxious particulate, the smoking, gases, and the myomas fuel and others. So it is our immense interest to change the definition by after many research. And there are other few important updates I would like to mention here. With the last 1 or 2 years after research and observational study, the Gold Committee declared this year. These are, we know that all the COPD patient become worse their condition after acute exertion, and acute exertion is commonly done after any bacterial or viral infection, and most commonly the bacterial infection. And now there is consensus that the Pseudomonas aeruginosa solely the colonization independently predicted the increased risks of hospitalization and for acute exertion and all the mortality of large observational study. A few large observational study they shown that, and Pseudomonas aeruginosa take the most of the part of the bacterial infection that causes the maximum acute exertion, hospitalization, and mortality. So it is very important about and careful management about these organisms, Pseudomonas aeruginosa, and this is the real picture after the last year research. And another thing, sometimes our acute exertion may be caused by not only bacteria but stress and different other condition, heart failure, stress, and other noxious material. Acute exertion of COPD may occur, and in proportionately and irrationally, the physician may start an antibiotic in that case. But the research committee they recommend that indicate the use of C-reactive protein and prolactin, procalcitonin and the C-reactive protein. After measurement, we can predict it is bacterial infection or not. If these are normal range, we should not use the irrational use of antibiotic. No need of antibiotic. We may manage in different way. These are two important issues of the last update. And another is important thing is that we all know that we are using LABA and LAMA, that is long-acting beta agonist and long-acting muscarinic antagonist, is the important treatment of COPD. A large observational pharmacoepidemiological study found that similar effectiveness of LABA LAMA and ICS LABA, but a significant higher risk of pneumonia in this case of use ICS and the LABA. That means the combination of long-acting beta agonist and the steroid, that is ICS, it equally effective like LABA plus LAMA, but the chance of pneumonia is more those who are using the steroid and the long-acting beta agonist. So this the recommendation is that LABA plus LAMA is more preferable than the ICS plus LABA. Eosinophil count. We know that many of the COPD patients have also concomitant allergic condition or asthma, concomitant asthma COPD overlap. How can we differentiate? It is the one important thing is the eosinophil count. The eosinophil count cell more than 300 per microliter should be regarded as estimated, and rather the precise cutoff values that can predict different probabilities of the treatment benefit and factor and the effect from the ICS. So those patients with COPD have eosinophil count more than 300 per microliter. We can effectively use the steroid combination with LABA in that case of patient, and we may be benefited from this type of patient. But those who have normal eosinophil count less than 100, in that case, the chance of any benefit from the corticosteroid is very less. Thirdly, the triple inhaled therapy. If we combine these three, LABA, LAMA plus the steroid, this combination is more effective in the LABA, LAMA combination. So in severe cases and those who are eosinophil high, we can use LABA plus LAMA plus corticosteroid. These are the few important recommendations from the 2020 goal update. And finally, we have few points like monoclonal antibody. We know that this is a very important thing, monoclonal antibody even using in various inflammatory condition of our body. Even in many cancer, in asthma, COPD, early there is always, and even in our COVID-19 cytokine storm. And 4 large observational study, phase 3 study, have investigated the use of anti-interleukin 5 monoclonal antibody, mepolizumab, and anti-interleukin 5 receptor antibody, benralizumab, in the patient with COPD and recurrent exaggeration and peripheral blood evidence of eosinophilic inflammation despite high intensity of inhaled therapy. The study showed that 50 to 20% reduction in the rate of severe exaggeration. So these are recommended in case of the severe, to prevent the severe exaggeration of the patient monoclonal antibody. And vitamin D, a very simple thing we are using in various purposes of vitamin D, but we usually found that those who are vitamin D deficient, in that case acute exertion and the COPD management become difficult. So it is a very in observational study, and the meta-analysis, vitamin D supplementation reduced the exaggeration rate in patient with low baseline level of the vitamin D. So it is also recommended in the treatment of the, to prevent acute exertion of COPD. Now we come to the point of COVID-19, because we cannot discuss in this pandemic any disease without adding the COVID-19, because everything is now are intermingled with the COVID-19. The COVID-19 come to us in the last January or December in Bangladesh in the March 8. After that, we are fighting against this pandemic. And there are different type of presentation and of the COVID-19, and some also already snatch away some life in Bangladesh, and also globally more than 10 lakhs or 12 lakhs already gone, they snatched their life. And many patients are with COVID-19 are asymptomatic, have mild symptom or moderate symptom, and also severe symptom. So the presentation may be asymptomatic 30%, mild to moderate illness in the upper respiratory tract is 50%, severe disease, those who needs HD or ICU with severe dyspnea and respiratory failure, respiratory more than 30 is about 15% only. And critically ill, those who are needing the life support, that the ventilatory support or hypotonic, only the 5%. So the mortality is most of this among this 5% of the patient, and rest of the patient usually we can survive with good treatment. And some patients have need totally no treatment. And now 49% of the critically patient having pre-existing comorbidity. Those who are critically ill patient, that is going for the mechanical ventilation or severe in the medical ICU, among them about 49% patient have the previous comorbidity. And among this comorbidity, COPD is number 1, and other like heart disease, diabetes, kidney disease, but COPD is in the point of 1 of the comorbidities that go to the critical condition and increase the cause for most of the mortality. So with this point and with this view, we should be careful about the early diagnosis and the management of COPD during the COVID-19 era. The comorbidity is a predictor of poorer outcome in COVID-19. And there are some study in Wuhan in 1590 laboratory confirmed hospitalized patient from 577 hospitalized in 31 province and outcomes region and provisional municipalities across the mainland of China between December 11th to 2019 to January 31st to 2020. This the graphical presentation and admission to the intensive care unit, invasive ventilation or death. And this is the according to the percentage. Some have no comorbidity and have 1 comorbidity, and some have 2 comorbidity. Those have comorbidities more, they have the more rate of admission and critical condition. Another important factor that we have known in the very early initiation of the COVID-19 regarding the ACE2 expression. We know that angiotensin converting enzyme 2 receptor is in various part of our body, but mostly it is in the airway. It's also in the GIT, the brain, and the kidney, and other parts of the body. It is present, but most of the ACE receptor is available in our respiratory tract. Angiotensin converting enzyme 2 expression is increased in COPD patient as well as the smoker. Those who are 20 package smoking completed, or those who are developed COPD in their airway, there is very much expression of angiotensin to receptor than those who are non-smoker and non-COPD. So the ACE2 expression was noted intensively in FEV. It is related to FEV1, that's forced expiratory volume in first second status, suggesting a dose response relationship also with that. And those who have high expression, their FEV is low. And finally, during the COVID-19 era, the scientists found that the COVID-19 severity is more with the ACE inhibitor, those who are smoker, and those who have developed the moderate to severe COPD. So COVID-19 entered the cell via ACE2 receptor. Therefore, the COPD patients are likely to more susceptible of developing COVID-19. COPD acute exaggeration associated with decreased mortality. If we can reduce the COPD acute exaggeration, we can reduce the mortality. The Kaplan-Meier survival curve, it is here, this is shown in the diagrammatically how the exaggeration prevention can reduce the mortality rate. Mortality increase with the frequency of severe exaggeration. So those patients in our home treatment with COPD, we are suggesting that they continue their treatment, full treatment, that no chance of they should give to acute exaggeration, and to prevent infection, to prevent the stress and other condition that they make their severe acute exaggeration. And if they affected with the COVID-19, the mortality chance is more. From this above discussion, we can conclude that early diagnosis, assessment, and treatment of COPD during the COVID-19 is very crucial to save patients from the possible life-threatening outcome. And how can we diagnose? Those who are already diagnosed in treatment is fine, but those who are not till diagnosed but are under diagnosis, we can, without investigation, we can, without other clinical assessment, some feature can help us to diagnose. This is a patient, is a 40 plus, and he has dyspnea, a chronic cough, and chronic sputum production, and history of the risk factor. History of risk factor like chronic smoking for more than 20 pack a year, has a different other exposure also, environmental exposure, and he has a dyspnea that is not always subsided, and this stay full that day minimum or to maximum, and he has chronic cough with sometimes unproductive and productive cough and chronic sputum production. This may give rise our idea for the diagnosis of COPD. We know that asthma and COPD, both the disease have chronic cough and shortness of breath. Asthma have cough and shortness of breath, and COPD have cough and shortness of breath. But this is different. In case of COPD, exertional dyspnea and chronic cough is the most important. In case of asthma, the shortness of breath is sudden, all on a sudden, it may goes any time. That patient forget about dyspnea. But COPD patient started the dyspnea and the whole that day, minimum to maximum. So it is important to diagnosis and with the history of smoking. The activity limitation is very common in case of COPD in the elderly population, and they cannot work, they cannot do the normal activity self, but they need assistance from the other. And same people of same age, those who have not smoking, no COPD. And airflow limitation play the central role in the development of COPD symptom. We know that in case of asthma also, there airflow limitation by the small airway constriction, airway narrowing. But it is about transient period. In case of COPD, especially the small airway firstly narrowed, that the bronchi and bronchiole, and then come to the large airway. So the early change of COPD is the narrowing of the small airway. And if we go the spirometry, we always give the we can diagnose is the point of the small airway obstruction, and there is not full-fledged airway obstruction in present in FEV1 and FVC ratio. But we get their signs in the small airway ratio, the FE forced expiratory flow in 525 or 75%, and it give an idea for the small airway obstruction. And this is the central role in the development of COPD. Sorry. What happens in early COPD? Early disease, the lung function, then we have giving some stage 1 and stage 2 COPD. Stage 1 COPD And this is the FEV1 FVC ratio less than 7, but FEV1 is normal, 80% of the predicted value. This is the part when FEV1 is 80% of the predicted value, but FEV1 by FVC ratio is 0.7. But in that case, we observe the small airway indicator that FEF 25, FEF 50%, FEF 70%, 75%, this will be reduced than the small airways. But in stage 2 and 4 COPD, there is clear cut the reduction of the FEV1 less than 80%. So from the spirometric data, we can predict the early change of COPD and the advances of COPD. Early disease, the exertional dyspnea, importance of symptom in early disease exertional dyspnea. Those who are the spirometrically normal findings, that is the FEV1 more than 80%, sometimes we report as the normal spirometry, but this type of patient have a small airway obstruction feature in the evident, and this patient we ask about their shortness of breathing, they always give rise to us the feature of exertional dyspnea, that he has no dyspnea in sitting, lying, or in the idle condition, but going upstairs, it even go normal, more than normal activity, will feel shortness of breath. And gradually, if we ask them, and if you ask him or her after 3 months or after 1 year, it will gradually progressive. So it is very important to note the exertional dyspnea with time expression. And why early diagnosis and treatment is important? Because it is very important the diagnosis of the COPD in early stage, because the lung function decline is very more in the stage 1 and stage 2, and stage 3 and stage 4 is less. Here we have the diagrammatic presentation that when the early stage of COPD, stage 1, the 40 ml per year, the reduction of the lung volume. In the stage 2, it is about 47 to 79% ml per year. But after a few years, when the patient advanced to stage 3, gradually it declined. So if we can diagnose the patient in the early stage 1, stage 2, we can halt the progress. As we already changed our definition, it is not non-progressive, we can halt. So if we diagnose the patient in the early stage of the disease, we start our strong management with LAMA, and other medication, we can stop the lung function decline and save and increase the quality of life. And it is very blessing for the COPD patient. Airflow limitation play the central role in the development of COPD symptom. We already discussed about this. The expiratory flow limitation and air trapping and hyperinflammation, this is the mechanism. Because when the small airway are narrowed, the expiration is more difficult than inspiration. So during expiration, some air is remaining in the alveolar spaces, and next breath more air is trapping, and gradually the air pressure increases and the air alveolar rupture and coalesces and give rise to the emphysema-like condition. So it is very important, and airflow limitation play a central role in the development of the symptoms of the COPD. Now it is vector. Another important thing we should mention: COPD is not asthma. Asthma is not COPD. If we are with all the chest physician, we are the senior physician, we know better. I think it is not for all, but those are the audience or the junior doctor or other, I like to mention very immensely upon this point. You never twisting this asthma and COPD together, and not the treatment in the same way, because where it's very easy to differentiate from just asking few questions to the patient. We can diagnose asthma, we can diagnose COPD. Asthma is totally, those patients who is suffering from asthma is innocent. Those patients suffering from COPD is 100% responsible for the disease. This two important thing, because COPD is smoking is the important cause of COPD, and other influence also there. But asthma mostly is familial condition, and more than 95% is from the genetic predisposition. So this is the important issue. And the airway inflammation is different pathway, and also the symptom is also different, and the cause is also different. And these are the different etiology, different symptom, different time of airway inflammation, different inflammatory cells, different mediator, different consequence of inflammation, different response to therapy, and different courses. You know that here, asthma, the sensitive agent is the important thing in case of asthma, because asthma airway is hyper-responsive. Asthma definition is that it is the clinical condition that makes the airway too much, too narrow, and too easily in response to various stimuli, that direct or indirect. That is, asthma airway is very hyper-responsive, and it comes to narrow in any sensitive agent. That may be dust, fumes, pollen, and others also. But COPD is not that. COPD is due to noxious agent, mainly the cigarette smoking, and that chronic irritation and other noxious material cause a gradual narrowing of the COPD in the airway, and that causes the COPD. And also the asthmatic airway inflammation is different way. We know that the inflammatory cell CD4, T lymphocyte, and eosinophil takes important part in the asthma pathway inflammation. But in COPD, the CD8 T and T lymphocyte, macrophage, and neutrophil play the central role. Also, and the cell, the neutrophil, macrophage, CD, this is already mentioned. And the key mediator in case of COPD is the interleukin 8, TNF alpha, interleukin 6, and nitric oxide. And in case of asthma, the epotaxin, interleukin 4, 5, and also nitric oxide. These are the things. And severe asthma and COPD is more or less same. That is the severe persistent bronchial asthma. Interleukin 8, interleukin 5, they are the same. Oxidative stress is more important in case of COPD than the asthma. So antioxidant is effective in the management of the COPD, but not in asthma, and also in case of severe COPD. The site of the disease, peripheral and the pathway is the most important in case of COPD, lung, parenchyma, and pulmonary. And the proximal airway is the main pathway in case of asthma. And consequences is the squamous metaplasia, mucus metaplasia, small airway fibrosis, and parenchymal destruction, pulmonary vascular remodeling, ultimately pulmonary hypertension, and pulmonary may initiate. But in case of asthma, the fragile epithelium, mucus metaplasia, basement membrane, and sometimes the subbasement membrane fibrosis occur in severe cases, and bronchoconstriction. Response to therapy, small the bronchodilator response, poor response to steroid in case of COPD. The steroid have less effective, but bronchodilator has less also have effect. But in case of asthma, the bronchodilator is the good response. Steroid also have good response. So the outcome of treatment in case of asthma patient is fruitful. Patient will be happy, doctor will be happy. But in case of COPD, patient will not satisfied, doctor will not satisfied, and they will try to desoldering the patient to other. And this is the picture of as management of asthma and COPD. And this is the also the cellular type, and we have in the pictorial we have shown the bronchoconstriction, airway hyperresponsiveness is the main thing, and asthma pathway, and a small airway narrowing and alveolar destruction is the main pathology in case of COPD. And mild asthma, and this is also the stimuli, also the TNF alpha, interleukin 8, GM, CSF, and that is the histone diacetylase is the important thing. We are coming to the next thing, histone diacetylase 2 and TNF alpha. And corticosteroid, we know that from the previous picture, we explained here that why corticosteroid is not effective in COPD, why corticosteroid is effective in asthma. This is the important thing. This is one important thing is the thing, the corticosteroid in the inflammatory gene in asthma is inhibiting by histone acetylase, acetyl transferase presented by the recruiting histone deacetylase 2. But in COPD, airway, and the chronic smoker, due to oxidative stress, free radical injury, giving the way to corticosteroid resistance, because histone deacetylase 2 is decreased in the COPD patient, those who are smoker. So the difference is that histone deacetylase 2 in the enzyme, this is markedly reduced in the COPD path airway, that is the smoker's airway, but it is normal in the asthmatic airway. And corticosteroid express its action by inhibiting the histone acetyl transferase by recruiting the histone acetylase 2. So in the case of the asthma patient, steroid is good effect, and in case of COPD, this corticosteroid has no effect or very minimum effect. But we can overcome this by reducing the oxidative stress and free radical injury by giving some few drugs like antioxidant and low dose theophylline. The antioxidant and low dose theophylline can overcome the condition to reducing the number of the histone deacetylase, and it will, after some days of treatment with antioxidant and theophylline, if we start steroid, it may be effective. So it is the new information from the class 2 year we are getting from the goal that those patients who are not responding to steroid, we can use theophylline or antioxidant for a few months, then we can replace it by the steroid. And the pathway diagnosis of COPD, and we are know that the COPD diagnosis is an important with the symptoms with other condition, MRC criteria, and every year it may gradually change. So some are symptom based and some risk factor based, and it is important. And goal 2020, the refined ABCD tool in new method for the assessment. In we are just for example here that this we know that the last from the 2017, 18, and 19, they are going to for the ABCD diagnosis of the COPD. It is very important, and it is correlating with the MRC criteria, MRC1, MRC2. Now this year, goal 1, goal 2, goal 3, and goal 4 according to the APV1. This is the APV1, and goal 1 is more than 80, and goal 2 50 to 79, goal 3 30 to 49, and goal 4 is 30. And if you consider by giving the example of the patient, those who have acute exaggeration and those who have not acute exaggeration, those who have goal D, the prior classification seems that, however, we find that the new proposed scheme, the subject with 3 to moderate exaggeration in the first year was initiated that level is the goal 4 and goal group D. Now it is graded in the goal 4, those who have acute exaggeration more than 3, and those who have the APV1 less than 30%. So this all the classification of the goal. And goal for the treatment of the stable COPD include the reduction of symptoms and reduction of the risk factor, relief symptom, improve exercise tolerance, improve the health status, and reduce the symptom. This is our goal of treatment. And then prevention of the disease progression, it is very important. Prevention of the treatment of acute exaggeration and reduce the mortality is our final goal. So all our discussion, all our effort is reducing the mortality of the patient and improving the health status, the quality of the life of the patient. And all the dear physician, all the friends and our colleagues, I like to highlight this point. So we should, after this discussion, we have some insight from the goal, and we will apply in our practical life in the treatment of COPD patient, so that we can make early diagnosis, we can make early treatment, and we can reduce the mortality, and also the for the betterment of the quality of the life of the patient. And the pharmacological treatment, finally, we know that these are the group C, A, group A before the goal 2019, that is group C, A, B, C, D. And A, the early stage, that is only bronchodilator may be effective in case of group A COPD. In group B COPD, a long-acting bronchodilator like LABA or LAMA, anyone that is indacaterol or glycopyridinate, anyone may be given. But those who are C, the LAMA, in this group C, there is more important is the goblet cell hypertrophy, hyperplasia, and secretion. LAMA may be effective, and group D, but LAMA, LABA, and ICS more maybe all may be tried. But it is the classification, but the physician, we will take our decision accordingly, which will be the betterment for the patient. But this is the basic treatment, that is the long-acting beta agonist, long-acting muscarinic antagonist, and the corticosteroid. These are the main 3 stages of treatment. And if needed, we add the antibiotic in the treatment. So rescue short-acting bronchodilator should be prescribed to all patients immediate symptom relief, because any patient with treatment, we give the ultimately SOS from the short-acting beta agonist in asthma and COPD both patients. So it is also should be treated as an additional. And the management cycle, so we will what we'll do, we'll assess the patient, because we know that we are giving inhaler therapy, that is MDI or any breathaler or unihaler. These all are go to our respiratory tract. It is not in the oral injection or not in the injection or suppository form. It is a very of struggle for delivering the medication. In different study, and also in my personal study of 130 patient, I found that most of the patient is careless about taking this type of medication, and also physician also very careless about the taking, how to use the inhaler. As a result, all the inhaler medication is deposited in the tongue, soft palate, hard palate. Few may go to the large airway, not in the small airway. This is very important to, you should prescribe the patient and come back the patient with the medication and show yourself from yourself, or ask the patient to show how to use the inhaler. If you ask the 100 patient, I definitely challenge you, 99% patient will wrongly use, and you will correct this and will follow up this. This will make big difference for the patient. And review the symptom, dyspnea, exaggeration, and finally escalate. When the patient is controlled, you can de-escalate and escalate according to need. And following the implementation of therapy, patient should be reassessed for the attainment of the treatment goal and the identification of the any barrier for the successful treatment. Following review of the patient response to treatment and inhalation, adjustment of the pharmacological treatment may be needed. And already we have discussed this, and the early prevention of exaggeration in the critical for the management of the COPD is very important. If we cannot early manage early diagnose the patient, the mortality will be 1 in 4. And dual bronchodilation helps to prevent exaggeration for your patient. This is the evidence in this picture here. And these are all about our today's discussion. Thank you all for your patience hearing. Mute, unmute, please. Moderator, unmute.
Sorry, sir. Thank you so much for your very much scientific and informative presentation. And from your presentation, we came to know about the very much details about COPD and the importance of the diagnosis and management of COPD in early stage. Now, I would like to request Dr. Adnan Choudhury sir to give his valuable comment on today's discussion.
Thank you, Mr. Moderator, for giving me the floor. I must first congratulate Dr. Abdullah Mamun for a nicely able presentation. So thereafter, I think there is very little to add. I'm now focusing on the latest updates, what Mamun has also elaborated very elaborately. The main 3 updates in the 2020 issue is number 1, regarding the decision about echo. This is asthma COPD overlap syndrome. Number 2 is biomarkers, and number 3 is ABCD grading system. So first, in the biomarker system, the biomarker is recently included in the very diagnosis and actually the management purpose of the COPD. In 2019, blood eosinophil level was first introduced as a biomarker, was recommended for biomarker, what Abdullah Mamun has said. And it is said that in the previous few years, we are mainly focusing on LABA-LAMA treatment of COPD patients. But a certain group of patients who are severely symptomatic, who are moderate to severe airflow limitations, and who have repeated or very severe exacerbations, in this group of patients, it is seen that LABA-LAMA cannot control the acute exacerbations, repeated exacerbations. So this group of patients may be benefited from inhaled corticosteroid therapy. So who were the patients who are benefited from mostly the inhaled corticosteroids? This group of patients are there who are blood eosinophil level more than 300 per microliter. They may be mostly benefited from LABA ICS treatment. But what about the patient who have less than 300 less per microliter and above 100? This group of patient may be benefited by LABA-LAMA ICS. So these are the 2 groups. And if the count is less than 100, so in this group of patients, ICS can cause no benefit, rather than it can cause pneumonia risk. So this group of patients should be treated with roflumilast and azithromycin. So this is the information of biomarker eosinophil. And latestly, this is the what Mamun has also said, that CRP and procalcitonin is added to management protocol. So for the antibiotic escalation and de-escalation. when there is a COPD acute exacerbations, if these levels are very high, the high level of CRP, high level of procalcitonin, we have to do aggressive antibiotic treatment. And during the treatment phase, whenever the CRP level, the procalcitonin level falls, we should de-escalate the antibiotic treatment. Number two is echo system. But asthma COPD volume system. Yes, Mamun briefly, very nicely elaborated. The committee has unanimously decided that there is no such syndrome exists as asthma COPD overlap. They have discarded this syndrome from the guideline, and they said that asthma and COPD are two different entities, completely different diseases. They may coexist in the same patient, but there is no such syndrome existed. So they eradicate this syndrome from the guideline. Number three is ABCD grading system. Mahmoud has elaborated it very nicely. Actually, in 2011, before 2011, the spirometric grading system was used to grading the patient, one mild, moderate, severe, and also the therapeutic decisions. But it has seen that this therapeutic decision is not very good, fruitful for the patient. So in 2011 edition, this ABCD clinical ABCD grading system was incorporated with the spirometric grading system. And in 2017 issue, it was completely separated, these two issues. That means the spirometric grading system is used only for number one, diagnosis, number two, prognosis, prognostic sector, and number three is non-pharmacological therapies. These three decisions should be made from spirometric grading system. And therapeutic decision should absolutely be given from the ABCD system, which Mamun has already described. And in the 2020 issue, there is another important update. That is, this ABCD grading system should be used in only first time decision making of the treatment. That means whenever you first encounter the patient, you follow him in ABCD grouping. But whenever the subsequent follow-up, if you a patient have come, suppose he is in group D, that means high risk and high symptom patient, and if you give a good treatment, he comes after 1 year to you. And if you think of ABCD system, then you will immediately fall him in A group, suppose less symptom, less risk. And if you deaccelerate the treatment, then the fault will be happen. So initial grading, he's always remain in group D. But you can de-escalate the drugs. You can give the treatable treat the treatable track. So this is the three most important thing. Along with in 2020 issue, this exacerbation issue is pinpointed with certain important differential diagnosis. So they say that you must exclude the diagnosis such as a pneumonia differential diagnosis in pulmonary embolism. Certain patients, COPD patients are most vulnerable to pulmonary embolism, and if they come with the same representation as COPD exacerbations, and if we treat this patient with exacerbation, aim to control the exacerbation, we will fall. Number two, there's some cardiological complication. Cardiology patient, heart failure patient may come, COPD and heart failure coexisted, and patient may come with heart failure, and if we treated it as COPD exacerbation, that will fall. So these are four things we have got in updated edition of 2020. Thank you all for this.
Thank you so much, sir, for your valuable comment. Now I would like to request Dr. Tasbirul Islam, as you were not connected with us during our introduction session, I would like to welcome you again and requested you to have a comment on is there any role of the primary care in early diagnosis and management of COPD? Dr. Tasbirul Islam.
My video is off, actually. Somebody disabled my video.
Oh, so sorry. But we can hear you. You may please continue.
All right, sure. Thank you so much for giving me the floor. And I thank you, Mamun, for a wonderful presentation. It's very informative. And Adnan actually touched very important few things. I want to go by few things quick. Number one is early, as Mamun says, early diagnosis and treatment and intervention is very important. 90% of the cases is related to smoking. In Bangladesh, maybe biomass exposure is one of the contributing factors for COPD, especially for the women. So that we need to careful about that. So taking history of the biomass. In terms of treatment, few things. First of all, that acute exacerbation of COPD, majority is due to infection, but we need to think if there's no evidence of pneumonia on the X-ray, and secondly, if there is no sign of infection, like if you look at the Antonison's criteria, increasing sputum production, increasing spirulency, and increasing shortness of breath. If you have 2 out of 3 with normal chest X-ray, we can think it is bronchitis, and bronchitis can cause exacerbation of COPD and require antibiotics. If the patient does not have features of bronchitis and no pneumonia, and patient came in with acute exacerbation of COPD, think of pulmonary embolism. It's very important. 25% cases when with normal chest X-ray and patient has acute exacerbation of COPD could be related to the PE. That is which Adnan says. I'm so happy that he mentioned that one. Other than the PE and infection, pulmonary edema, pneumothorax, and arrhythmias can cause exacerbation of COPD, and poor compliance. Always check whether the patient is taking their inhalers rightly. Inhaler technique is good. That is number one. Number two, now the treatment for the COPD is more phenotypically directed. What is phenotypically directed? Means looking at the patient's appearance and looking at the biomarkers, which is Adnan says of the biomarkers, such as, is it an emphysema you're dealing with? You're dealing with chronic bronchitis. Are you dealing with asthma with COPD, overlap syndrome? Are you dealing with frequent exacerbator or rare exacerbator? Are you dealing with rapidly declining COPD or not rapidly declining COPD? Are you dealing with predominantly upper lobe emphysema or not? And are you dealing with wheezing COPD versus non-wheezing COPD? But the treatment is very different, such as if it is chronic bronchitis, we use roflumilast. That is one of the phosphodiesterase 4 inhibitors. But if it is more emphysema, probably it doesn't work. Number two, if it is asthma overlaps COPD overlap syndrome, in that case, steroid works. Principle of treating COPD is basically LABA and LAMA, then steroid later. But if somebody has asthma, COPD overlap, probably will use steroid earlier than the LAMA. So that is another important thing. Somebody has predominant emphysema, upper lobe emphysema, probably a patient will benefit from the surgical lung volume reduction surgery or bronchoscopic lung volume reduction surgery. Someone has more wheezing dependent or wheezing related COPD or alpha-1 antitrypsin deficiency, they will benefit from alpha-1 antitrypsin replacement, but there is a criteria. Is somebody FEV1 less than 60%, but FEV1 more than 35% of the predicted, and patient has alpha-1 antitrypsin deficiency, they will benefit from the replacement therapy. But important thing, any COPD patient, not like in the past, we used to say below the age of 40, basal emphysema, or some liver problems, they are actually most likely had alpha-1 antitrypsin. But in now the criteria said any patient diagnosed COPD, even at the age of 60, 65, should have alpha-1 antitrypsin level, should be checked. So in summary, I would say the early diagnosis is very important. History in terms of smoking, biomass, number two. And number three is, can you hear me? Yeah, biomass, history. And number three, the inhaler technique is so important. Number four is not only the infection cause acute exacerbation COPD, we need to think about PE, pulmonary edema, arrhythmias, pneumothorax. Number four, phenotypical characteristic is so important. So look at, is asthma predominant, bronchitis predominant, or emphysema predominant, upper lobe emphysema predominant, or it is wheezing and not wheezing, alpha-1 antitrypsin deficiency. We need to look at those and tailored therapy according to what the patient has. And in rule of thumb, LABA-LAMA should be the starting, and the inhaled corticosteroid will be the last one to add as a triple therapy. But for somebody has asthma, COPD overlap syndrome, or somebody has eosinophilia in the blood, or sputum eosinophilia, or patient has wheezing, they will benefit from the inhaled corticosteroid. Daliresp or roflumilast is only for the chronic bronchitis patient, not for emphysema patient. Long-term treatment with the azithromycin is beneficial. I think you should consider those for long-term treatment. Pulmonary rehabilitation is the key, and oxygen therapy. These two showed mortality benefit, nothing else. So exercise program, pulmonary rehabilitation is so important. And oxygen therapy, who needs oxygen if the saturation is below 88%. Last and not the least is we need to be vigilant. We need to do the breathing test. Any smoker patient, significant smoking history, meaning 20-pack year history, should have a lung function test. Many patient has not symptomatic, but if you do the PFT, lung function test, you'll find the evidence of emphysema or COPD. And the vaccination is very important. Make sure they got pneumonia vaccine and flu shots. Pneumonia shot after the age of 65, 2 shots, PCV 13 and PCV 23, but the flu shot every year is kind of mandatory for COPD patient. And smoking cessation program is so important. We need to re-emphasize, not like tell you to quit smoking, you have COPD. That's not the way it works. You have to spend time. Maybe we can do physicians are very busy in Bangladesh. There is only 86,000 physicians in Bangladesh. So if we can do nurse-led smoking cessation program, the nurse will talk to the patient, giving advice, then call the patient, make sure they're sticking, not smoking. That kind of thing we can approach. Thank you so much.
Thank you so much, Dr. Takbirul Islam, for your valuable and very much informative discussion. And now I would like to Professor Dr. Mahbub Noor Sir, Brigadier General Mahbub Noor Sir, to have his valuable comment on today's discussion. And please, sir. Sir, please unmute your microphone. Sir, please unmute your microphone.
Now unmute. Okay. Thank you, moderator. I first give thanks to Dr. Mamoon as well as Dr. Adnan and Dr. Tasveerul Islam. They actually elaborately they discuss pathophysiology as well as the management. Now I am actually especially I want to add some few words about in the management of this COVID patient, COPD with COVID patients in critical care area. The usual medical management of COPD patients acute, they are actually presented with the acute respiratory failure with the COPD involves nebulized bronchodilator therapy and non-invasive ventilation and sometimes a high flow nasal cannulas prior to committing the patient to invasive mechanical ventilation. These therapies increase aerosolization of the SARS-CoV-2, and this increases the risk of exposure of healthcare workers. Actually, this COVID COPD with COVID patients, you already mentioned, Mamoon, that only 5% patients of severe COVID pneumonia patients actually admitted in ICU, and these patients actually the normal usual medical management it cannot be performed because the main thing is that the bronchodilator nebulization bronchodilator therapy cannot be performed in this type of patient for only the main reason is that aerosolization of the SARS-CoV-2 virus. And this acute respiratory failure, this patient actually presented with type 1 failure, that is a hypoxemic respiratory failure, or maybe type 2 respiratory failure, there is a hypercapnic respiratory failure. In case of a type 1 respiratory failure, the patients with the COPD and COVID-19, we give first we start the controlled oxygen therapy as the first step. And once these fail and increase the oxygen supplementation, then we go for we go for work of breathing, and then additional for benefit we then start the high flow nasal cannula. This high flow cannula it is the hypercapnia and work of breathing might be additional benefit of high flow cannula in patients with COPD and COVID-19 patients. And in type 2 failure, there is a hypercapnia. Here, NIV, that is a non-invasive ventilation, should be considered. But here, hypronasal cannula is an additional benefit. We can utilize that hypronasal by using the flow and the oxygen level. We can be reduce. We can be additional benefit we can get from the hypronasal cannula. Before starting hypronasal cannula or non-invasive ventilation, it is willingness of undergoing invasive mechanical ventilation from the patient should be discussed. And this invasive mechanical ventilation should be instituted in patients with a severe hypoxemia, hypoxemic respiratory failure, and NIV failure. This is the actual procedure for we start going for the invasive mechanical ventilation. And there are some recommendations with the for this treatment. The recommendation is that patients should be switched to bronchodilator therapy through metered dose inhaler or dry powder inhaler in lieu of nebulization route whenever possible. Metered dose inhaler should be utilized with a spacer, and long-tail dual bronchodilator is also preferable. And another thing is that when using nebulized therapy, the high flow nasal cannula and NIV, healthcare workers in the room should wear PPE appropriate for airborne precaution. And then NIV should include inspiratory and expiratory viral filters. And patients wearing high flow nasal cannula should wear a surgical mask, which reduces the airborne dispersion of exhaled particles. And the risk of co-infections increases in the severity of the COVID-19, the bacterial and the fungal infections. I have a small study in Evercare ICU, in the COVID ICU. In the last 3 months, we have treated about 40 patients in last 3 months in the COVID ICU, COVID patients. These are among these patients, COVID patients, COPD patients with COVID is 15 patients. And among these 15 patients, 5 patients were on mechanical ventilation, and we extubated 1 patient. And the rest of the patients, that is out of 11 patients, shipped from ICU of COVID, COPD with COVID, and 11, that are the 11 patients. And these patients actually treated with controlled oxygen therapy as well as a high flow nasal cannula. This is the outcomes of the last 3 months in my in Evercare Hospital COVID ICU. Yeah, we have treated these COVID patients also in COVID HB also, but in COVID ICU, there's around 40 patients, 15 patients as the COVID. Thank you.
Thank you so much, sir. Your discussion was full of data and very much informative also. Now I would like to request Professor Dr. Shahabuddin Talukdar sir to have his valuable comment on today's discussion. Professor Dr. Shahabuddin Talukdar sir, can you hear me? Sir, can you hear me? I would like to request our technical support team to check the support. Sorry, audience. Now I would like to request Professor Dr. Roshni Jahan ma'am to have his valuable comment on today's discussion. Ma'am, please unmute your microphone. Thank you, ma'am.
Welcome. Thank you very much, and assalamu alaikum. It's a great privilege for me to talk and share my experiences with this special panelist. Assalamu alaikum. And first of all, I'd like to congratulate Dr. Mamoon for his elaborate and very informative, excellent presentation. Now, uh, actually, most of the things has been discussed. I'd like to just point out some of the points which are needed to be very during the diagnosis, especially in the early stage of COPD. We should remember some of the points, and we should take some of the meticulous history from the patient so that these patients cannot be missed or underdiagnosed. Number one, in case of female, in 2020 goal guidelines, they have also mentioned that COPD is increasing in case of female. And what is the reason? We should ask not only the biomass fuel, also the second-hand smoking. The husband is a smoker, so she is affected. So we have to take that information also. What are the causes, other causes besides this biomass fuel? And this is important also in the management purpose, because in case of female COPD, when they actually the female patients are also suffering from vitamin D deficiency, especially at this stage after the 50 years. So they should be given supplemental vitamin D. That is very important. And in the goal guideline 2020 already has been discussed some of the important points. And another point I'd like to mention, and that is during the history and diagnosis, we should also ask the patient regarding their habit, their smoking history, because most of the patients are not giving that actual history. So they hide that they are the smoker. So that history to be taken meticulously. And another thing is that the patients should be assessed about their complications, at what stage they are presented in front of the healthcare provider or the doctors. What are their complications, whether already they have got the complications of COPD or not, or they are at the early stage. So we have to make a very meticulous plan in order to have a good effect or benefit for the patient by giving effective planning of management. And management should include not only the pharmacological as well as non-pharmacological point is also very important. Like it has been already discussed, compliance of the patient, especially regarding the inhaler technique. And also we have to give them a very positive attitudes towards life, because most of the patients, when we have seen them, they are not in a positive attitude. They have lost their hope that we won't survive. So in that case, we have to give them encouraging points. We have to give them a plan regarding their, especially I would like to say about the rehabilitation. Regarding their diet, regarding their lifestyle management, regarding their vaccination, regarding their taking the way they are taking the drugs, regarding everything. That means a complete and total management plan should be given so that they can get the full benefit out of this from the doctors. And another point is that while we are diagnosing a patient with COVID and COPD, we have to think about the symptoms of the patients of COPD. In COPD, in the earliest stage, they don't have any symptom also. But if we take the history, they used to give that they have got the cough, occasional cough, and while they work, I mean the exertional dyspnea is present. So this is very important to identify in order to diagnose these patients at the earliest stage. And as soon as we are suspecting the patient may be a case of COPD, uh, we have to have some investigations, including the spirometry, which is very important. And we have done the spirometry, and that recording should be kept and preserved, so that in future we can compare whether this is progressing or not. This is very important. So we have to, and at the same time, we have to exclude the other differentials for COPD, like CT scan or HSCT. Sometimes patient doesn't have any symptom, but if we do the HSCT, there is a bulla. So that can also help us to diagnose in the early stage. Sometimes in the family, we have to take the family history also. In the guideline, they have also mentioned this time that alpha-1 antitrypsin deficiency, we have to take wherever we have the facilities, we have the options to to do the alpha-1 antitrypsin level, we have to do that, and we have to take the decision. So by that, we can also early diagnose. Early diagnosis is very important, prime important in that, so that we can manage the patient at the early stage. And about the COVID, Mamun has said, yes, there are some patients, most of the patients have got some symptoms, but and a group of patients are asymptomatic. But when we suspect COPD, we have to assess the patient then and then by doing like CT scan or HSCT, because in COPD, Mamun has said in the guideline, in COPD, there is upregulation of AC2 receptor. So that has to be noted and kept in mind. And other thing is that we must be very particular regarding the vaccination. Most of the time, patients, they neglect, they don't bother, and they don't take the vaccination. So this is also, I think, is very important for them to take the pneumo vaccine. And another thing is that regarding the patient's nutrition, which is very important in the early stage, we should not be confined to only to the pharmacological aspect or drugs. We should ask them, we should encourage them to take regarding the dietary habits, which includes antioxidant, fruits, and their lifestyle, which is stress. To reduce the stress, they must be given a nice plan so that they can improve their quality of life. So these are some of the important points we should do at the very beginning to diagnose, to manage the patients efficiently. That will give them a good quality of life, and they will survive. And one last but not the least thing, most of the time we know that 20% patients die of COPD die during sleep. So they must be particular when the patient, if the patient is on LTOT, or if they need the supplemental oxygen, they must take it at night in order to prevent that death. And most of the things have been already discussed, so I don't want to say anything more. That's all. Thank you very much, and thank you, everybody.
Thank you, Professor Dr. Roshni Jahan ma'am, for your sweet and nice discussion. Now I would like to request Professor Dr. Shahabuddin Talukdar sir to give his valuable comment on today's discussion. Sir, can you hear me? Sir, please unmute your microphone first.
No.
Thank you, sir. Yes, sir. We can hear you.
Thank you very much for inviting me as a cardiologist. It is my pleasure and privilege to attend this session. I learned many things. Most important thing nowadays, the COPD is not a progressive disease, it is a preventable disease. Mamun has expressed nicely and elaborately, and very good discussion has happened. So I have nothing to say. But as a cardiologist, I must say, the COPD and the cardiac disease are interrelated in terms of some causes, in terms of signs, in terms of symptoms, and in terms of treatment also. So when in my clinical practice, I have seen 30 to 40% patients of cardiovascular disease are COPD. 20 to 30% patients of heart failure suffer from COPD. 10 to 15% patients of cardiovascular disease suffer from COPD patients suffer from arrhythmias. So these are very much important that if we can control earlier the COPD and you can prevent, you can avoid the patient, you can compline the patient to treat their COPD, we can prevent this complication. Regarding signs, symptoms, and treatment, it is very easy to distinguish. Mamun has very nicely elaborated. From my side to the junior doctors, I must say, take a meticulous history of the patient, examine the patient, and do some investigation. That's all. Nothing more required, just ECG, rather than physical examination and signs and symptoms. Take an ECG, do an echo, take an X-ray, spirometry, some biochemical tests like eosinophils, like your proBNP, like your CRP. You can distinguish from the COPD patient with heart failure, or whether it is cardiac asthma or bronchial asthma, or there is COPD, or it is clinically it is a cardiac heart failure. So thank you very much, Dr. Mamun and others. Thank you, Dr. Tasbir, Dr. Adnan, Dr. Mamun, Dr. Professor Roshan. As a cardiologist, I must say that I learned many things. One thing is very important for the patient, for me, for the doctors and juniors and seniors, that it is nowadays it is preventable, treatable, and curable disease. Thank you very much. Thank you again, all the panelists and speakers. Thank you very much.
Thank you, thank you, Professor Dr. Shahabuddin Talukdar sir, for your short and very much nice discussion. Now, I would, if you permit, I would like to take some questions from our audience. Sir, can I take some questions? Dr. S.M. Abdullah Mamun, sir.
Yes, you can take a question from the audience, sure.
Thank you, sir. Mr. Joynal Abidin emailed us. He told that I am Joynal Abidin, 62 years. I am a patient of COPD for the last 10 years. Recently, I recovered from COVID-19. My COVID period was not so serious. Some mild symptoms were present with saturation of partial pressure of oxygen 92 to 93%. I became negative on 7th November. After 8 days, I want to know, is there any chance of lung damage of mine as a post-COVID effect?
Okay, thank you. I again in the discussion, I just note a few points, then I will ask the answer. Our discussion is now very full-fledged and complete, because my discussion was initially restricted to the COVID-19 early diagnosis and management during the COVID era, but many other things was left, because COPD is a very vast thing, and we present this in the 3 or 4 parts. It will complete total COPD. But our panelists, expert panelists, Dr. Adnan Bhai, Dr. Tasbir, and Dr. the ICU specialists and cardiologists from the 4 angle, and they are there are different other points that are missed in my discussion, and this is not included in our topics are included. So the full-fledged discussion of COPD, I think, from this our panelists. And few points like the surgical option, that is the volume reduction surgery and the valve replacement. This is also important in the new coming era, another stem cell treatment. But this is our, if we may give any opportunity to further discussion, we will make this. Regarding the question of the patient, he is about 60 and COPD, 62 years, suffering from COPD, and also she is now recovered from the COVID-19. COVID-19 and COPD patient is very lucky. I congratulate him for this our successful treatment, because our regarding our severe COPD patient with COVID-19, our the result is not rewarding. But this patient already recovered, and if he done an HRCT of the chest and what's the condition of the lung involvement, it is important. Otherwise, his oxygen saturation is 92-93% in the room air. It's also very fine. I think his chance of complication is very less. But now he will do, if he not done, he can do an HRCT of the chest. And what's the treatment he was taking for the COPD previously? You should continue during the total COVID era in the future few months, not to stop any treatment and management. And if after giving a CT scan of the chest, if any get any result and any involvement is more than 40 to 50%, I think we will come to our respective physician. We will consider for him any antibiotic therapy or not. We will consider. Otherwise, he can stay home with oxygen needed. If needed, he can do the low dose oxygen therapy. Already Roshni Appa mentioned that 20% of the COPD patient die in the night during the low oxygen situation, because we know that the oxygen saturation is virtually very minimum, about 92-93% in a COPD patient, and during sleep period it will virtual reduction. And especially we are not discussed the sleep apnea. Many patients have the obstructive sleep apnea among this type of patient, and these are very risks of oxygen low saturation in the night. Those type of patient can use oxygen in the night time for their safety during this COVID period. For this patient, I think he can continue his treatment, and after any change in this HRCT, we will contact with the any test physician. And another, for finally, in our today's session, I like to extend my thanks to all the panelists and also to the Unimed UniHealth Pharma for their contribution and for their help in arranging this vast discussion program. And I hope in the future they will extend their hand for this type of academic program, and that can help our physician, our patient, and our also to increase and revise our knowledges from the different angle. Thank you very much. Thank you all.
Thank you so much, sir. Thank you, Mr. Janalagedi, for your question. We hope that you will get your answer. Today, we have a very great discussion on the importance of the early diagnosis and management of COPD in COVID-19. And now I would like to conclude our today's session with thanks to our honorable speakers and our panel of experts for this wonderful discussion. I wish you good health and very good night, and assalamu alaikum.
Finally, special thanks to Tasbir Bhai for his within his busy schedule of ICU round, he gave us important time and delivered his knowledge for us. Very much thankful to Tasbir Bhai.
Thank you, Mamun. Thank you, Mamun, for inviting me. It's my pleasure always. Thank you.
You are watching Raj